Welcome. In the previous 4 sessions, we discussed about age-related macular degeneration, and we'll continue with the acquired disorders of choroid, Bruch's membrane, and retinal pigment epithelium before we take up retinal vascular diseases, hereditary vitreoretinal disorders, and retinal detachment. Pachychoroid spectrum of diseases need to be differentiated from age-related macular degeneration, and we are going to discuss the differentiating features between the two in this session. So the diseases included in the pachychoroid spectrum include pachychoroid pigment epitheliopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, polypoidal choroidal vasculopathy, and peripapillary pachychoroid syndrome. We'll discuss about central serous chorioretinopathy in the next session, and we'll be discussing about the remaining entities, particularly polypoidal choroidal vasculopathy, in this session. These disorders may coexist in the same eye or change from one form to another form over time. So this photograph shows a patient with CSR with underlying features of pachychoroid, which we are going to discuss. Defining criteria of pachychoroid spectrum include certain features on OCT, certain ICGA features, and absence of extensive drusen's on clinical examination. The OCT features of pachychoroid spectrum can be present either in a diffuse or focal distribution in the fundus, but what is most important is these three features should be co-localized in the same area of the fundus. And these three OCT features include relative increase in choroidal thickness in affected areas as compared to unaffected areas, attenuation of the inner choroid, that is the choriocapillaris layer and or the satellites layer, and dilatation of large choroidal veins in the hallux layer, which are called pachyvessels. And these pachyvessels are the key feature of pachychoroid disease. And as we shall see, pachyvessels violate the watershed zones between drainage areas of adjacent vortex vein systems. So in this OCT we see large pachyvessels in the outer layer of choroid and increased thickness of the choroid along with RPE changes. As we shall see, presence of pachyvessels is more important than increase in choroidal thickness for diagnosis of pachychoroid spectrum. And as we have discussed in an earlier session, choroidal thickness is usually reduced in age-related macular degeneration, whereas it is increased in pachychoroid spectrum. And the defining ICGA feature of pachychoroid spectrum is choroidal vascular hyperpermeability. So we note here that indocyanine green angiography instead of fluorescent angiography is important for diagnosis of pachychoroid spectrum. And on clinical examination, there is a lack of soft or extensive drusen's and other typical features of age-related macular degeneration. Another clinical features which suggest the presence of pachychoroid is history of or evidence of previous central serous chorioretinopathy. Choroidal thickening can occur in otherwise healthy eyes in the absence of symptoms or signs on clinical examination when it is called uncomplicated pachychoroid. And even if choroidal thickness is normal or subnormal, if characteristic fundus changes, which we are going to discuss, are found over pachyvessels, the eyes are considered to have pachychoroid. So increased choroidal thickness is not a prerequisite for diagnosing pachychoroid, but presence of pachyvessels or dilated vessels in the outer choroid is. And there are two quantitative measures which may enable us to diagnose pachychoroid. One is a reduced ratio of inner choroidal thickness to total choroidal thickness, which can be used as a measure of inner choroidal attenuation, which is an important characteristic of pachychoroid, and choroidal vascularity index, which is the ratio between the choroidal vascular luminal area to total choroidal area either on OCT or on ICGA. Measurement of choroidal vascularity index requires a specific software, and unlike choroidal thickness, which may vary considerably within the normal population, choroidal vascularity index has a more consistent value in the normal population. But there is no consensus regarding the upper limit of normal choroidal thickness, and many consider 300 micron as the upper limit of normal subfoveal choroidal thickness. Normal choroidal thickness varies with age, axial length, and location in the fundus. Subfoveal choroidal thickness may actually be normal in a patient with pachychoroid elsewhere in the fundus. Pathogenesis of pachychoroid is still unclear, and association with thick sclera and short axial length suggests impaired choroidal drainage either through the transscleral or through vortex vein routes, ultimately resulting in inner choroidal ischemia. Clinical findings in pachychoroid include RPE disturbance, subretinal fluid, macular neovascularization, and aneurysmal lesions, which we'll discuss as we take up the individual pachychoroid entities. As we have discussed, pachychoroid spectrum is characterized by its imaging features on OCT, OCTA, and ICGA. On OCT, we will find large diameter choroidal vessels in the outer choroid, as seen here in this OCT scan from a patient with pachychoroid, in comparison to normal diameter vessels in the outer choroid in a patient with a normal choroid. But there is no normative data to quantitatively assess vessel diameter so as to have a cutoff between the normal vessel diameter and a pachyvessel diameter. The other OCT feature of pachychoroid is thickening of the choroid, as we find here in this patient with pachychoroid in comparison to a patient with normal choroid. And this is the line defining the outer limit of the choroid in this eye, and this is the line defining the outer limit of the choroid in this eye. And as we have discussed, there is no consensus regarding the upper limit of normal choroidal thickness, and thickness of the choroid may actually be within normal limits in a patient with pachychoroid. This is another OCT scan in a patient with pachychoroid, and we find the large choroidal vessels in the outer choroid, which may actually span the entire thickness of the choroid, and RPE disturbances overlying these pachyvessels. Focal choroidal excavation is another feature of pachychoroid, which is a concavity on the inner surface of the choroid with or without a space separating the choroid from the retina, which are called non-conforming focal choroidal excavation and conforming focal choroidal excavation respectively. But focal choroidal excavation is not an exclusive feature of pachychoroid and may be found in many other entities such as myopia, AMD, and chorioretinal inflammations, with congenital focal choroidal excavation being the most common form of focal choroidal excavation. In-phase OCTA in pachychoroid spectrum shows pachyvessels in the macular area which remain dilated and may terminate abruptly. Normal choroidal vessels, in contrast, taper as they progress towards the macula, and choriocapillaris flow deficits may be found in the inner choroidal segmentation of OCTA, suggesting ischemia of inner choroid as seen here in this photograph. Indocyanine green angiography in pachychoroid spectrum shows the pachyvessels as a cluster of relatively straight and dilated choroidal vessels, and whereas in a normal fundus, the larger choroidal vessels taper as they move towards the center of the macula, the pachyvessels in the macular region remain dilated without tapering. In early phase of ICGA, delayed arterial filling and pachychoroidal filling defects suggest ischemia of the choroid, and in mid to late phase of the ICGA, choroidal vascular hyperpermeability can be detected as patchy areas of choroidal hypercyanescence as seen here in this photograph. And CVH is said to be due to leakage of protein-bound ICG dye from choriocapillaris into the choroidal stroma. CVH is often found surrounding pachyvessels as seen here in this photograph. This is another set of ICGA photographs of the right eye and the left eye showing areas of choroidal vascular hyperpermeability, and these leakage areas slowly expand in size from middle to later phases, and in the later phases of ICGA, areas of hypocyanescence develop in the centers of these areas of ICG leakage, resulting in a ring-like shape. Among the pachychoroid entities, we will be discussing central serous chorioretinopathy in the next session. Pachychoroid pigment epitheliopathy, or PPE, is characterized by RPE disruption overlying areas of pachyvessels in eyes without active or evidence of prior central serous chorioretinopathy. If there is evidence of active or prior central serous chorioretinopathy, the diagnosis is central serous chorioretinopathy and not pachychoroid pigment epitheliopathy. Pachychoroid pigment epitheliopathy is often found in fellow eyes of unilateral central serous chorioretinopathy, and so pachychoroid pigment epitheliopathy is considered to be forme fruste of central serous chorioretinopathy and may predispose to future development of pachychoroid neovasculopathy or polypoidal choroidal vasculopathy. Pachychoroid pigment epitheliopathy is often asymptomatic, and on clinical examination, RPE mottling as seen here in this photograph and pachydrusms, which are focal and isolated yellowish irregular elevations of RPE, as seen here in this photograph, are found. Both RPE mottling and pachydrusm in pachychoroid have a predilection for extrafoveal location as compared to drusms and RPE changes in AMD, which have a predilection for fovea. In pachychoroid, there is a reduced tessellation of the involved area of fundus, as seen here in this photograph. Fundus autofluorescence in pachychoroid pigment epitheliopathy shows patchy hypoautofluorescence, as we see here in this photograph, with focal areas of hyperautofluorescence. And OCTA in PPE shows focal disruption and thinning of the outer retina, as we have seen in a photograph earlier in this session. Other imaging features of pachychoroid will also be found in PPE. In peripapillary pachychoroid syndrome or PPS, maximal choroidal thickness occurs adjacent to the optic disc and is typically associated with intraretinal and/or subretinal fluid in nasal macular retina and in retina nasal to the optic nerve. So this is an OCT scan of a patient with PPS showing thicker choroid nasal to the fovea as compared to the thickness of the choroid temporal to the fovea, and on ICGA, pachyvessels are found in the nasal macula. PPS is occasionally associated with optic disc edema. In PPS, other signs of pachychoroid spectrum are also found to be located adjacent to the optic disc, as we see here in this photograph, with reduced tessellation of the fundus occurring adjacent to the optic nerve. And PPS, like PP, is often asymptomatic, but it is important to identify PPS in patients with optic nerve edema so as to avoid unnecessary neuroimaging and other investigations for optic disc edema. Pachychoroid neovasculopathy or PNV is characterized by development of a type 1 macular neovascularization overlying areas of pachyvessels but not associated with aneurysmal dilatation. So the macular neovascularization in pachychoroid neovasculopathy is located between the RPE basement membrane and the inner collagenous zone of the Brooks membrane. And if this macular neovascularization is associated with aneurysmal dilatations, the diagnosis would have been polypoidal choroidal vasculopathy. Pachychoroid neovasculopathy eyes may have associated pachychoroid pigment epitheliopathy and active or evidence of prior central serous chorioretinopathy. Exudation from pachychoroid neovasculopathy results in subretinal fluid with or without interretinal fluid, but lipid exudation and hemorrhages are uncommon with pachychoroid neovasculopathy. OCT-B scan of pachychoroid neovasculopathy shows a shallow irregular RPE elevation, also known as SIRD or double layer sign, with heterogeneous hyperreflective content with or without subretinal or intraretinal fluid, as we see here in this photograph. So this photograph shows serial OCTs of the same eye in a patient with pachychoroid, showing development of pachychoroid neovasculopathy longitudinally over time. Fluorescent angiography may show an occult type leakage as seen here in this photograph, but may be obscured by diffuse RPE disease. ICGA may show a plaque type hypersenescence, but this also may be obscured by choroidal vascular hyperpermeability, which is a characteristic imaging finding of pachychoroid spectrum. So these two photographs are from a patient with pachychoroid neovasculopathy showing the pachyvessels, subretinal fluid and pachyneovascularization appearing as an SIRD or double layer sign. The double layer sign is made up of the RPE layer and the ICZ layer of the Brooks membrane, and a hypercyanescent plaque is seen on indocyanine green angiography corresponding to the location of the SIRD. OCTA shows a tangled network as seen here in this photograph between the retinal pigment epithelium and the Brooks membrane, and OCTA may be more sensitive in detecting macular neovascularization of PNV as compared to fluorescent angiography and indocyanine green angiography. Other imaging features of pachychoroid spectrum, which we have discussed earlier, will also be found in eyes with pachychoroid neovasculopathy. Polypoidal choroidal vasculopathy, also known as PCV or aneurysmal PNV, is clinically the most important entity in the pachychoroid spectrum, and the key features of polypoidal choroidal vasculopathy on ICGA are a branching vascular network or BVN with terminal aneurysmal dilatations of the BVN. The branching vascular network is a type 1 macular neovascularization present between the basement membrane of the RPE and the inner collagenous zone of the Brooks membrane. The branching vascular network continues to grow and develop newer aneurysmal lesions in its margins over time. Recurrent sudden onset exudation and hemorrhage occur from the aneurysmal dilatations and not from the BVN itself. Unlike type 1 MNV of neovascular AMD, fibrous proliferation is uncommon from branching vascular network of polypoidal choroidal vasculopathy. Similar aneurysmal lesions may occur along with type 1 MNVs from other causes such as age-related macular degeneration and myopic maculopathy, but these will not have the typical imaging features of pachychoroid. The typical clinical presentation of polypoidal choroidal vasculopathy is the occurrence of multiple serous and hemorrhagic pigment epithelial and neurosensory detachments as seen here in this photograph, and it is said that 85% of patients with hemorrhagic pigment epithelial detachments have underlying polypoidal choroidal vasculopathy. In addition, deep orange-red spheroidal lesions may be detected as seen here in this photograph, which correspond to aneurysmal lesions detected on ICGA. ICGA is considered the gold standard to detect polypoidal choroidal vasculopathy. An early phase of ICGA shows the branching vascular network followed by slow filling up of aneurysms. Aneurysms can show pulsations, and larger aneurysmal lesions may show plasma erythrocyte separation. Mid and later phases on ICGA show staining of the margins of these aneurysmal lesions with a central hypocyanosis, also called dye washout from the aneurysms. In these two photographs, we see a localized area of hypercyanosis on ICGA corresponding to the orange-red nodule on clinical photograph, and the hyperfluorescence on the corresponding fluorescent angiogram is much less prominent than the hypercyanosis in the indocyanin green angiogram. OCT may show the polypoidal lesion, which appear as narrow sharp elevations of the retinal pigment epithelium appearing as inverted U, along with other features of pachychoroid spectrum. OCTA is said to be more sensitive than indocyanin green angiography in detecting the branching vascular network as seen here in this photograph, but is less sensitive than indocyanin green angiography to detect the aneurysmal lesions because of low flow velocity within the aneurysms. Pachychoroid pigment epitheliopathy and peripapillary pachychoroid syndrome do not require any treatment and should be monitored for development of other pachychoroid entities. Non-exudative pachychoroid neovasculopathy does not require treatment but should be monitored for future exudation. But exudative pachychoroid neovasculopathy needs to be treated with anti-VEGF monotherapy. Studies on PCV are more extensive, and most studies were based on ICGA detection of aneurysms but did not distinguish between aneurysms associated with pachychoroid and aneurysmal type 1 MNV associated with non-pachychoroid entities such as neovascular AMD. The Everest 2 trial compared ranibizumab monotherapy versus combined verteporfin PDT and ranibizumab in polypoidal choroidal vasculopathy in Asian patients over 24 months, and a total of 322 patients were included. All patients received 3 once-monthly loading dose of ranibizumab followed by PRN regimen of ranibizumab, and for patients in the combined group, PDT was repeated as required on a PRN basis. And the Everest 2 trial showed that combination therapy was superior to monotherapy as regards BCVA change, and combination therapy was also superior to monotherapy as regards polyp regression, which was defined as absence of hypercyanescent polyps on indocyanin green angiography. And the combination group also required fewer ranibizumab injections and required a mean of 2.2 verteporfin PDT treatments over the 24 months. The PLANET trial compared aflibercept therapy versus combined aflibercept with deferred PDT in polypoidal choroidal vasculopathy patients of Asian and European origin, also over 96 weeks. All patients received 3 once-a-month aflibercept injections, and at 12 weeks, patients were stratified into those requiring rescue therapy and those who did not require rescue therapy. Those who did not require rescue therapy continued on aflibercept injections once every 8 weeks, but those who required rescue therapy at 12 weeks or any subsequent scheduled visits received aflibercept once every 4 weeks till resolution and were randomized to receive either verteporfin PDT or sham PDT, which was repeated after 3 months if required. So in the PLANET trial, both randomization and institution of PDT treatment was done 12 weeks after initiation of the trial. 318 patients were included in the PLANET trial, and at 52 weeks it was found that aflibercept monotherapy was non-inferior to combined aflibercept and PDT. Less than 15% of patients required rescue therapy with PDT, and monotherapy and PDT showed similar reductions in central subfield thickness. And similar results were also found at 96 weeks. And so the PLANET study concluded that rescue PDT did not provide additional benefit over aflibercept monotherapy. Other trials on aneurysmal lesions included Fujisan and Altair, and the Hawk and Harriet trial, which we have discussed in the earlier session, in which a subgroup analysis was done in patients diagnosed with exudative AMD but having polypoidal lesions. And this analysis showed that BCVA gains with brolucizumab administered either once every 8 weeks or once every 12 weeks was comparable to aflibercept administered once every 8 weeks. But anatomical outcomes favored brolucizumab, with no fluid on OCT being detected in almost 90% of patients receiving brolucizumab at both 48 weeks and 96 weeks. Several case series evaluated bevacizumab for polypoidal choroidal vasculopathy with limited resolution of the aneurysmal lesions, and laser photocoagulation has also been used for extrafoveal and extramacular aneurysmal lesions, but limitations of laser photocoagulation include scarring, retinal pigment epithelial tears, recurrence of aneurysmal lesions, and occurrence of macular neovascularization. If we compare pachychoroid spectrum with AMD, there is a difference in the currently accepted pathogenesis of the two entities, with pachychoroid spectrum being said to be due to choroidal congestion and AMD said to be due to diminished transfer of oxygen and nutrients from the choriocapillaries to the RPE and outer retina through the sub-RPE deposits. Pachychoroid spectrum is more common in Asians, particularly East Asians, and AMD is more common in whites. Pachychoroid spectrum diseases have pachydrusen instead of extensive soft drusens or subretinal drusenoid deposits, which are found in AMD. RPE changes and pachydrusen in pachychoroid spectrum have a predilection for extrafoveal retina as compared to RPE changes and drusen of AMD, which have a predilection for the foveal area. Typical imaging features of pachychoroid include pachyvessels with or without thickening of the choroid. In contrast, in AMD, we characteristically get thinning of the choroid. Risk of neovascularization is lower in pachychoroid spectrum as compared to AMD. Pachychoroid occurs in a relatively younger age group as compared to AMD, and the genetic alleles in patients with neovascularization in both pachychoroid spectrum and in AMD have been found to be similar, and it is said that these alleles induce neovascularization but do not cause pachychoroid characteristics per se. Visual prognosis in pachychoroid is better than that in AMD. Pachychoroid and AMD can be present in the same eye or in the two eyes of the same individual. Pachychoroid can have non-aneurysmal MNV, which is called pachychoroid neovasculopathy, and neovascular AMD can have aneurysmal type 1 MNV but without the typical imaging features of pachychoroid. To recap the salient points, pachychoroid spectrum is characterized by dilated choroidal vessels or pachyvessels in the outer choroidal layer, attenuation of inner choroid with or without thickening of the choroid, all of which occur in a focal or diffuse manner in the same regions on OCT called colocalization, choroidal vascular hyperpermeability on ICGA in the absence of extensive soft drusen and other characteristics of AMD. Other imaging features of pachychoroid spectrum which can be detected both on OCTA and early phase of ICGA are broad and non-tapering pachyvessels passing through the macula and filling defects in the choriocapillaries. Several entities show features of pachychoroid spectrum, including central serous chorioretinopathy, which we will discuss in the next session. More than one of these entities may coexist simultaneously in the same eye or transform from one to another in the same eye. Pachychoroid pigment epitheliopathy is characterized by RPE mottling and isolated pachydrosion with a predilection for extrafoveal areas in an eye without a previous history of CSC. Peripapillary pachychoroid syndrome is characterized by pachychoroid features localized to nasal macula and temporal to disc. Optic disc edema can occur in PPS. Pachychoroid neovasculopathy is characterized by a type 1 MNV which shows a shallow irregular elevation of RP on OCT, a tangle network in sub-RP space on OCTA, and a plaque on ICGA. Polypoidal Choroidal Vasculopathy or PCV is characterized by a branching neovascular network BVN, which is a type 1 macular neovascularization with aneurysmal dilatation at the edges of the BVN. The BVN is best detected by OCTA and the aneurysmal dilatations are best detected by ICGA. Clinically, PCV is characterized by recurrent episodes of multiple serosanguinous neurosensory and pigment epithelial detachments. The aneurysms may be seen clinically as deep orange-red spheroidal nodules. PPE and PPS require monitoring for future development of other pachychoroid entities. PNV, if exudative, needs treatment with anti-VEGF. For PCV, Everest trial showed the superior efficacy of combined ranibizumab and PDT as compared to ranibizumab monotherapy, and Planet trial showed similar efficacy of aflibercept monotherapy as compared to combined aflibercept and deferred PDT. Subgroup analysis of patients with aneurysmal lesions in Hawk and Harriet trials showed similar efficacy of brolucizumab as compared to aflibercept as regards visual outcome, with superior anatomical outcomes with brolucizumab in polypoidal choroidal vasculopathy. Thank you for listening.